schedule of benefits will also indicate a specific elimination period for the insured, your client. The elimination period is a time designated in the policy that the insured has to pay out of pocket. They have to receive covered services and pay out of pocket during this period before benefits can be paid. The schedule of benefits will indicate the specific duration of the elimination period, typically anywhere between 90 all the way up to 180 days. What's also important to understand for the elimination period is, like the other terms and conditions on the schedule, what is on the schedule is not necessarily always accurate. One example is we've come across quite a few of these types of policies where the policy defines day, so day in the elimination period, as 1 day of covered services actually equals 7 against the period. So that is a huge benefit to insureds and clients. So it's very important to understand how this policy defines the specific elimination period. And part of that is also what constitutes covered care under the elimination period. It's an issue that we come up against quite a bit, and it's whether or not Medicare covered days in skilled rehab can be counted towards elimination period. I think Steve will give us some examples of cases we've dealt with in the past about that and how you can determine whether this specific policy allows that or not.
So like Kevin mentioned, the elimination period concept can be complex. It's not as straightforward as someone might think. It's not like a deductible that we all understand with a homeowner's claim or some property claim. It's a durational issue, and it can be technical. We've had cases where an individual, as Kevin mentioned, had to be hospitalized, wound up in rehab, and they come out and they need home care. Home care is arranged, claims are submitted, and the claims are stalled because the elimination period had not been met. If the policy is silent about whether those stays are covered or applied toward the elimination period, they do. And because if the policy doesn't mention it, it cannot create a barrier to accessing benefits by deeming some event not consistent with the policy provisions. So it's very, very important for providers to understand that and to look very carefully at the policies to see whether or not the policy specifically does not allow, or is silent on whether skilled nursing would count toward the elimination period.
I think it's also important for providers to understand, maybe during their initial intake, to ask about prior rehab stays and to understand that if this person has a policy, those days can potentially be applied to the elimination period. It's great for the client. Obviously, they're getting credit for the elimination period, which equals less days out of pocket, and it's great for the provider because their client's going to be reimbursed faster. So it's something that you have to be aware of all the time, especially someone coming out of the hospital or skilled rehab. And then as an additional matter, a lot of the newer policies have these additional benefits for a care coordinator. It's a nice service for the insured, but what's really important for the provider is that the insurance companies incentivize the insureds to use the care coordinator. And one of the incentives is if you use the care coordinator, the insured may be able to have their elimination period waived. So if you see a care coordinator benefit in a policy, it's imperative that you take a look at it to understand if my client uses this care coordinator, are they able to utilize the waiver? That's a huge benefit to insureds.
There are also policies that will apply the elimination period toward a facility benefit like a nursing home or assisted living, but not apply it for home care. So it's very important to really dig into the policies to make sure that that your client has or doesn't have a policy where the elimination period is not going to be applied towards home care, whereas it would be applied towards facility care. So that's just another thing to look for.
And then the last thing to think about as a provider during the elimination period is that most of the policies, at least none that I've come across, and you can let me know if that's the case for you, but none that I've come across dictates an hour minimum to count towards the elimination period. So you as a provider have to be aware of that, but also it shows some goodwill to work with a family during this time, to maybe if you have a 4-hour minimum, to work with them and offer a 3-hour minimum during the elimination period so that they're out of pocket less, but still get credit for those days. So it's a really good way for you to build some goodwill with the family and to help them work towards the period and hopefully gain a long-time client in the process.
And really, for a lot of insured people, paying out of pocket for 90 days or 120 days is something they cannot manage financially. So when we're dealing with a client who's in a situation like that, we're very careful to counsel them about receiving a minimal amount of care during the elimination period so they can afford to get through it. But that has to be carefully balanced against the care needs of the individual. Because I could not, ever in good conscience, counsel somebody to get less care than they actually need and put them in peril. So it's a balancing act, and it's one that requires a lot of concentration and understanding of what the care needs of this individual are and whether or not the care can be managed at a lower level safely until the elimination period is met.
Once you have an understanding about some of the specifics and the terms and conditions of the policy, the next thing you need to understand are the specific benefit triggers, meaning what the insured has to do in order to qualify for benefits. Generally, there are two main benefit triggers. The first is the chronic illness trigger, which can also be known as assistance with ADLs. The second is a medical necessity trigger. In most long-term care insurance policies, the chronic illness trigger encompasses two things. One is whether the insured requires assistance with their activities of daily living, which most commonly is defined as bathing, dressing, transferring, continence, toileting, and feeding, and or a cognitive impairment. And the standard for that is usually whether the impairment is severe to the extent that the insured requires supervision to protect him or herself. In order to meet the chronic illness trigger for a functional claim, meaning assistance with activities of daily living, most of the time, an insured must require assistance with at least two of the activities of daily living. Now, what's really important to note here is that the activities of daily living listed in policies sometimes change depending on the policy. So if you assume that the activities that I've just listed are in there, you could be in danger. For example, I had a case recently where the insured was receiving assistance with bathing and dressing. Typically, those are common covered ADLs. Now, unfortunately, in this particular policy, bathing is not a covered ADL. So obviously, in this case, the insured's claim was denied. So what you first have to understand are what are the specific ADLs that are listed in the policy, and then you can move on from there. The next thing you have to understand is whether the policy will count hands-on assistance versus standby assistance as covered care. I think you can give us an idea of what the difference is between the two and how you can understand how you have to go about depending on what the specific policy covers.
Well, there's a massive difference. I mean, hands-on assistance implies a much higher acuity level of the individual. By the time somebody is in need of hands-on assistance, they're impaired substantially. And some policies do indeed require only hands-on assistance. The tax-qualified policies that connect the chronically ill language to it actually require that standby assistance also be a covered trigger. So it's very important to know that. We've had a lot of cases where the chronic illness standard is actually in the policy, but they omit standby assistance as a covered trigger. So how have we dealt with cases like that? Well, again, we go to the statutes, and in the case of a chronically ill standard, you have to go to the federal statutes because it's what is called a tax qualified policy. So just like state-driven policies have to comply with state statutes, so too the tax qualified policies have to comply with the federal tax regulations. So we go to the federal tax regulations and we see that in order to qualify as a tax qualified policy, the insurer must also cover standby assistance. People have to understand that standby assistance is a critical benefit trigger because some people can indeed perform their own activities of daily living, but not safely. They might be a fall risk. There may be a problem with the bathroom being slippery, whatever the case might be. Standby assistance affords the person the opportunity to have somebody in close proximity to them while they're carrying out their own activities of daily living. And that is enough to trigger a benefit under the policy. The second benefit trigger in every long-term care insurance policy is the cognitive impairment trigger. Now, most of the policies define cognitive impairment and they describe it as needing to show a severe cognitive impairment in order to qualify for benefits under that trigger. To be clear, a person with a, quote, severe cognitive impairment can be fully functional and be able to manage all of their activities of daily living without any assistance. But if they have a cognitive impairment such that they are a risk of harm to themselves or others, then the policy will trigger a benefit for supervision by a home health agency or home health aide to supervise the individual to make sure that they don't get into trouble, like leaving, getting in the car and driving when they shouldn't, et cetera, et cetera. The nuance in this trigger is what is considered to be a severe cognitive impairment. The way that we have always presented it and advocated a cognitive impairment claim was simply whether or not the person's cognitive impairment is such that they are a risk of harm to themselves or others. And if that can be established, then the claim is payable. Now, the cognitive impairment trigger does require clinical evidence of a cognitive impairment, and that could be in the form of a mini-mental status examination, which can and should be performed during the time of the assessment to develop a plan of care for an individual who's contemplating using their policy for services. The cognitive impairment issue is tricky because sometimes an individual can appear to be very cognitively intact, but digging deeper into the analysis over their behavior could reveal problems with judgment, and many times we've had to have our clients undergo a neuropsychological evaluation, which is a much more sensitive test to tease out cognitive impairment and functionality, way more sensitive than a mini-mental. So I think the takeaway here is that when there's a cognitive impairment issue that you are addressing on behalf of one of your clients, you have to be very, very careful and completely understand the trigger and what it takes to perfect that claim. But just remember the simple tagline, if you will. If the cognitive impairment is such that the person is at risk of harm to themselves or others, that person should be able to get their benefit.
And as a provider, what you really need to impart on the families is oftentimes people believe that just because they have a diagnosis, that's sufficient to warrant benefits under their policy. We get calls all the time saying, my husband was diagnosed with dementia, I'm ready to use the policy. That's just part of the process. The diagnosis is the first part. Like my dad said, objective clinical evidence is the next part that imparts to the insurance company the level of severity and the issues that the insured is facing as a result of that diagnosis. So you have to create a narrative that explains exactly what's going on with the insured. First, you show that there's a diagnosis, and then you have to explain how it manifests. But many people early on with a dementia diagnosis can function pretty well. A lot of people still drive with early diagnosis of dementia. So you have to understand that on its face is not sufficient. You're going to have objective clinical evidence that shows that there's more depth to the issue than just that. And like my dad said as well, a perfect example is we've had a client who was scoring quite high in the mini mental status exam, where based on her score, she was, quote, moderate impairment. But the family knew that there were deeper issues there. So we advised the client to go to a longer, more in-depth neuropsychological evaluation, where those tests are considered the gold standard for cognitive impairment. Now, those tests will certainly pick up things that a 30-question questionnaire mini mental status exam will not. So if you have a family where they're explaining all of these issues with their family member, saying their score on the mini mental doesn't line up with what we're seeing in reality, there could be more there. The answer to cases like that is to seek more sensitive testing. Doesn't necessarily mean that their claim cannot get approved. It just means that they have to do a little bit more legwork to make sure that the claim file supports what they're saying.
And also, the claims are not just technical claims. There's other evidence that would suggest that a person has a cognitive impairment that could and should be made part of the claim. One is, are they missing their bills? Are they missing their doctor appointments? Are they making mistakes with math? Are they repeating themselves? So I think that when a provider is looking at an individual and they're contemplating bringing a cognitive impairment claim, those questions should be asked. How is Mr. Jones functioning, et cetera, et cetera, et cetera? Because that is part of the claim, that should be part of the claim package that is presented on behalf of the individual.
And just as a practical matter, as a provider, if a family comes to you with a cognitive impairment claim and they're seeking to use their long-term care insurance benefits, it makes a lot of sense to have them undergo a mini mental status exam. It doesn't have to be a nurse that performs the test. You or I could perform that test. It's just a series of questions. And that right there will give you an initial baseline to at least inform the family of how difficult a claim may or may not be. Obviously, if there's people scoring very low, extremely impaired, the worry or the danger of the claim getting denied is much less. But if someone's borderline in the moderate to medium impairment level, you have to tell the family that they can expect some potential pushback and that they're going to have to do some work on the claim. Unfortunately, these days, getting an appointment with a neurologist is very, very difficult. So we have plenty of clients that have an impairment but don't have any medical records to support that. Those are very difficult claims to get approved. So if you have a family like that, the first thing you have to tell them is you're not ready to submit this claim. You need to get your medical evidence and your medical records in order before moving forward. And as a provider, that would save you a lot of headache, where down the road, the family may say, what's going on? My claim is not approved. What do? I need your help. Well, that way you have at least told them what they need to do to get the claim like that approved.
And just maybe the last thought on this, people are living longer. And in my 20 years of handling these claims, I've seen how long people live. And the longer they live, the more likely it is that a cognitive impairment is going to evolve and develop. So it's definitely something that we all have to understand and observe and be tuned into.
So in addition to the chronic illness or the ADL trigger, certain policies have a different trigger, the medical necessity trigger. This is much less common than the ADL trigger policies, and you can usually find them in the older policies. The main difference between this trigger and the trigger we've already discussed is that these claims are much easier to perfect than those are. In the case of a medical necessity trigger, the standard really is whether a doctor or a licensed healthcare practitioner has indicated that the insured, based on their diagnosis, requires home care. It's as simple as that. A doctor just has to say, in their medical opinion, the insured requires the necessary care, home care, or whatever other care they believe is necessary.